I'm Chris Green, Member of Parliament for the Bolton West constituency, and I'd like to welcome everyone to this first meeting of the all-party parliamentary group on health infrastructure. We've just had the AGM. I'm pleased to say that we've been successfully constituted, so we're now a functioning APPG, and we have a great opening meeting ahead of us. So in the main part of the meeting now, well, actually, it's a revived all-party parliamentary group for healthcare infrastructure. Our purpose is to highlight the importance of the physical infrastructure of health and social care, and how high-quality health infrastructure is essential to the delivery of high-quality healthcare to patients. You will have heard just now about the wide range of parliamentarians who are participating. So there's me, Chris Green, Catherine Smith, Philip Dunn, Lord Naseby, Lord Bradley, Anandaciva, Javid, Sakiti, Fletcher, Baroness Greengross, Mel Ribeiro, Andy McDonald, and others who were indicating they'll be present at the meeting. But Catherine Smith, Therese Villiers, Lord Naseby, our Vice Chairman, and the officers are Nick Fletcher, Belrio, Addy, Peter Dowd, and Baroness Jolly. So we have a good complement, a cross-party complement of colleagues. So I think this is always a good indication of the importance and value of the health infrastructure work and the importance it is to our country, both the physical and digital side. Hopefully we'll be able to ensure that it doesn't become a party political issue. It is one that benefits all of us and is an integral for supporting our National Health Service heroes in the vital work they do every day. In chairing this group, I hope we'll be a critical friend to the government and help inform the policy debate and outcome in this area. The timing for our reformation is not coincidental. Last month, the Chancellor announced the first multi-year capital funding settlement for the NHS since 2015, and the largest uplift in over a decade, taking spending to £11.2 billion by 2024-25. That funding was welcomed and provided much needed clarity for supporting our health service in getting the facilities and estates and equipment it needs. However, whilst the headline increase in spending is welcome, this group wants to ensure this opportunity is used to both support the NHS as it emerges from the pandemic and to lay the groundwork for meeting the future needs of staff and patients. Today's first session is a stocktake, a recognition of the place the NHS estate and infrastructure are in right now. The infrastructure, both physical and digital, played an important role in helping our health service cope with the demands of the pandemic. However, the last 2 years have also reflected profound challenges. It is these we will explore in our first meeting. We have a panel of esteemed speakers to guide us through this topic. Alan Johnson needs no introduction, not least of all after his recent star turn on The Masked Singer. However, he can also offer insight both from his time as Cabinet Secretary of State for Health, Cabinet Secretary of State for Health, and as the independent chair of the City Care Health Estates Company. Nigel Edwards is the Chief Executive of the Nuffield Trust and an important voice in these debates with a wealth of experience to draw on and enlighten us with. And finally, Siva Anandaciva from the King's Fund will be taking us on a deep dive inside the current state of the NHS estates. So thank you all for attending, and there's going to be a Q&A at the end, so please, as we go through listening to these speakers, do please take notes of the questions you have. And I think I ought to note on behalf of Honourable Alan Johnson, is normally I'm sure there'll be a book signing, book sale after or during these meetings, but there probably can't be this time, so do please go online for that, but I'll hand over to Alan Johnson.
I think we're having some trouble with Alan getting into the meeting, Chair. Could we perhaps ask Siva to go first, if that's okay? We're having some issue with Alan logging in.
Thank you. Siva, over to you.
Thanks. Thank you, Chair. And I have to go first. Let me just share my slides. That's all right. Mike, can you, or Bruno, would you mind confirming you can see those? Great, thanks.
Yep.
Well, thanks everyone for the opportunity to come and talk about a topic I'm really passionate about, actually, the healthcare infrastructure and the health and care state. What I wanted to do in my 10 minutes is just give you a broad overview of the current condition of NHS buildings, facilities and equipment, why that matters to patients and the public and staff, and what's being done about it. So I'll dive straight in. Every year, the NHS does a survey of its existing buildings and equipment and assesses the condition. And what you're seeing here in this chart is the cost of tackling all the maintenance issues that are built up over the years with those NHS buildings, facilities and equipment. So the dark brown lines show that over £9 billion is the current estimate of what it would cost to eradicate the backlog of maintenance issues that has built up. And if you look at the other bars, they show you broadly that the mix of these issues is for the most significant, the most high risk issues to be building up more quickly, particularly over the last few years, than lower risk issues. I don't know about you, but for me, things like low risk, high risk, significant, moderate, it can leave you a bit cold. What are we actually talking about? I think this is one area where actually the data definitions are hair-raising enough to give you the picture. So for high risk issues, that would cost billions to eradicate. We're talking about issues with buildings and equipment that must be addressed with urgent priority in order to prevent catastrophic failure, major disruption to clinical services, or deficiencies in safety liable to cause serious injury or prosecution. So you may have seen reports about the condition of buildings. We are not talking here about shabby carpets and other liquid paint needed. We are talking about incredibly serious issues. If that's what the national data shows us, a second point I wanted to make is there's huge variation across the country. So what I've done here is just take that highest risk group of maintenance issues and look at where each individual provider trust, NHS trust, falls in its share of these high risk maintenance issues. And you can see there is clearly a London issue. Imperial, parts of Barts Health, including Whips, which is my local in the Hillingdon, accounting for a huge share of the national backlog. But London doesn't have a monopoly on knackered estate and tired equipment. And another point I would make is look at somewhere like Northumbria Healthcare. Now, if you look at Northumbria's footprint, it has some absolutely outstanding estate, like Cramlington Hospital, and it will also have some estate in very poor condition. So I think the purpose of this slide is to show that, yes, we've got a growing national problem. It is not evenly distributed across the country, and even within particular discrete areas, there's still a lot of variation. And the third data-related point I'd make is, understandably, me and other people focus a lot on hospitals, and I think there's good reason for that. You will have seen reports about rack concrete planks or aerated bubbly concrete. There are some hospitals and schools in England that are at risk of the ceilings falling in because of the type of concrete and how it degrades over time. You walk into these places and you can literally see the metal pillars, the temporary metal pillars that are in place to hold the ceiling up. So it's understandable why there's such focus on hospitals. But if you were to look at mental health services and the proportion of people who still receive inpatient care in dormitory style accommodation, if you look at GP premises, and again, it's a story of variation, but there's still some premises that are simply not fit for purpose. And while there's poorer data available, you look at care home and nursing home stock, and we know it is aging. We know that in some cases it's less fit for purpose. I think overall, we've got a really worrying picture painted for the whole health and care estate. So I've talked about billions of pounds needed to eradicate backlogs. I've talked about 85% of care home stock being aged. Why does it matter? And I think for me, there are three reasons. The first is lower productivity at a time when the NHS is absolutely trying to maximize value for money. Can you imagine that in some cases, I know it's an extreme example, but the NHS is having to pay to bespoke manufacture replacement parts for equipment because the equipment is so old the manufacturer no longer supports it. Old medical scanners are less productive than their modern counterparts. The most important issue is clearly the impact on patient care. And again, I'd ask you to imagine turning up to your appointment that you've been waiting for, often in anxiety, often in uncertainty, to be told either that it has to be rebooked because the scanner is on the frisk, or that you have your scan completed and the clinical professional looks at it and says, the resolution isn't clear enough, I'm going to have to send you down the road, which has also happened to services. And probably the less reported aspect is on staff experience and efficiency. So some mental health providers will rota extra staff because they're needed for observation where you can't remove ligature points. And the water handover, which is not database, it's an anecdote. A friend of mine who is on the board of a hospital, and I asked him how his weekend was, and he said, I was the director on call, so I was in charge of the water handover. And I said to him, why are you getting involved in clinical matters? Why are you involved in fluid management? And he just gave me a really strange look and said, no, the water handover is where the director on call needs to make sure that every agency nurse who doesn't normally work on the site has been told that because our gutters don't work, when the damp starts getting to this point in the wall, you need to start unplugging equipment. And that's what he was having to do. These are the levels of workarounds, again, in extremis in some cases, that affect the NHS. A lot of this is probably not new, and I think a lot of the strategic issues will also not be new to you. So Robert Naylor, who was the chief executive of UCLH, and I think it was an affectionate term, he was called Bob the Builder because he made capital and estate strategy such a core part of his job as a chief exec, wrote a review in March 2017 that identified some of the underlying issues with why the estate had gotten into the shape it was, including whether there was sufficient headroom and capability in the NHS to tackle both the operational and strategic agenda, a real diverse view on where accountability best sits. And the review was written at a time when you would broadly have individual provider organizations in the NHS and national bodies involved in estates planning. Now, of course, we have integrated care systems that will also play a role in the accountability structures. Red tape and approvals and late notice on capital funding being available. I think this is an issue that comes up over and over again and is remedial and doesn't require a massive transformational effort or masses of new funding. It is an issue that could be tackled quite quickly. And also, Sir Robert identified the competing demands because you've got knackered estate and equipment that need to be tackled now to maintain current assets at the same time as developing the estate of the future to make the most of modern clinical medicine and healthcare. So I'll start to finish, and I didn't want this to all be doom and gloom. The first thing I'd say is that capital budgets are increasing. So what you're seeing here, and sorry, I should have said you'll get all these slides, of course. What you're seeing here is the Department of Health's capital investment budget for about a 20-year period, and it has been a roller coaster. There was the period after the great financial crisis when purposefully money was transferred out of capital investment budgets into day-to-day spending. We're now in a period of growth. We are in a period where we were aiming to have 40 to 48 new hospitals or new hospital facilities in the country. So if you look at funding, there may not be enough to cover both the backwards and forwards investment, but it will broadly, by the end of the spending review period, get the UK back to close to the OECD average for industrial nations and what they spend on capital infrastructure. The second element that means I'm not completely doom and gloom is the work that's already underway. So tomorrow we'll see the announcement of the winners of the Wolfson Economics Prize that this year looks at radical new hospital designs for the future. The bottom is an illustration of what the new Whipps Cross Hospital might look like, which is part of the early pathfinders for the government's hospital building program. And Whipps is my local, and I can tell you everyone has a call on additional funding, but Whipps is infamous for the standard of its estate, and to see proposals for the first time in a generation, I think is giving hope to the local community. And the third and final example is in the top left, which is that grass-covered hospital, which is Alderhay Children's Hospital. I want to focus on Alderhay because they were going to build a very different type of hospital until they talked to the children and said, alongside staff, obviously you're going to be the people using this building. What do you want? And alongside a request for privacy, for dignity, they wanted green space. They wanted something that didn't feel like a traditional hospital, and that is what they got. And the reason I bring up Alderhay is it was before the government building programme. It was built at a time when capital budgets were still going down. Obviously, you see the need for a national coherent framework for a state strategy, but I think we need to keep a sense of local agency, finding a problem and solving it. And I think that's what the board at Alderhay did. So my final slide is to pick up some other issues to perhaps bring forward into the discussion later or the Q&A. The first is I've been covering health and care infrastructure for a long time, and at times it's felt like shouting into the dark. But I have to say it's gone up the agenda, both funding and the strategic issue, in a way I haven't seen in years, even if the reality check is the new funding provided by the government is not a bonanza. It will not be able to meet every call on its demands. The second thing is I've probably spoken from a very narrow parochial NHS view. Whether or not in 10 to 15 years' time we have 40 to 48 new hospitals will depend as much on supply chains and construction costs. It will depend as much on labour workforce shortages in the construction industry, which are out with the NHS's control. The third thing is there are all sorts of, the way in which we build hospitals and other facilities is changing. And I think issues like alliance contracting and modern methods of construction may sound boring and technocratic. When you're asking people why aren't these new facilities coming online, developing these at pace might be part of the issue. The fourth point I think I've already made, but I probably can't emphasize enough. What I want to avoid is in 10 years, us looking back and saying we have 40 brilliant new hospitals, when actually what we should have been investing in is 40 brilliant health and care infrastructure campuses or networks of different facilities to deliver modern clinical care. And the fifth and final point is clearly the demands on healthcare in the medium term and short term are uncertain. Clearly we are building things that can last for generations. Given those two things, I don't think you can put a high enough premium on flexibility, adaptability, avoiding overspecification. And that is a point that Nigel Edwards actually taught me. So I think this was a point when I was going to either hand over to Nigel or Mike, hand back to Alan if he's with us now.
Thank you, Siva. That's a brilliant introduction. Really appreciate that. And Alan Johnson has now joined us, but if we can go to Nigel Edwards first.
Thank you. Yeah, I was about to commit the sin of talking while muted. I shall share my screen as well. So I'm going to pick up some of Siva's comments and learning. He's covered the territory extremely well. I'm going to look back about what we might learn from the previous hospital building programme and pick up a few points. Siva's covered a number of them very well, so I won't labour them about thinking about the next. Siva optimistically says we'll get back to the OECD average. One has to say that we've been so far below the OECD average for so long that seems like a thin gruel. When compared with other major OECD economies, we massively underinvest in infrastructure generally, and that is also true in healthcare, and that leaves us way behind, not just in terms of hospital buildings, but in terms of our diagnostic equipment, and that has major implications for patients, and is partly behind our poor international figures on things like cancer survival. So put in the long-term context here, even the bonanza of the early 2000s hardly gets us close to the average, and that was really, there was an astonishing amount of money poured into hospital and primary care development at that point. And as you can see, as Siva says, the last 10 years or so, We've really been bucking a trend where other European countries have been putting money into infrastructure, which I think has been perhaps a mistake we shouldn't continue to repeat. Let's look about some of the lessons from the last forecasting. So a common problem in the last programme was massive over-optimism about the ability of the system to manage demand and to reduce length of stay. There is undoubtedly a very substantial opportunity to reduce length of stay in hospitals, but we have not made the investment, particularly in rehabilitation and community services to do that. And very often services were planned, but without a concomitant investment in those areas. Rehabilitation is another area where we are a big outlier compared with the rest of Europe, and you'll generally find that about 15–20% of patients in hospital don't need to be there because they are waiting for some form of rehabilitation, either institutional or home care. And then, of course, the other component of that is social care, and I don't need to tell you at the moment just how precarious the social care system is. If you think the NHS is in trouble, I'm sure those of you who speak to the providers of social care will think that the NHS is relatively well off compared with the disaster zone that social care looks like at the moment. So you can't empty your hospitals if you haven't got those services, but people made bed forecasts which were reverse engineered to meet their financial projections, and as a consequence a number of hospitals at some expense had to put beds back in after they had been built. Notably Norfolk and Norwich and University Hospitals Birmingham both had been asked to make very ambitious changes. Second lesson, which Siva really referred to, which is we still plan hospitals, but hospitals are embedded in systems, and if you don't make the other investments, your hospitals don't work. And hospitals on the whole were also poor at thinking about how what they were doing would connect to the wider economic development agenda, but in terms of creating opportunities for SMEs on their site, creating training and development opportunities, and linking into local transport and housing plans. I think they're getting better at that. Third lesson, lots of idiosyncratic designs based on the preferences of the consortia who were building them, or the clinicians they spoke to. Not nearly enough standardization in these designs, and nowhere near enough testing and simulation. Flexibility does cost money to build in. But if you think designing flexibility and building it in is expensive, you should try not having it when you need it. That then becomes very expensive, and we've unfortunately got quite a lot of buildings which the flexibility was not incorporated into the system. So one of the things that happens, I'll refer to it later, is possibly one of the most misnamed processes in this area is called value engineering, which is you find your scheme is too expensive, and then people come and strip out various components of it. One of the things that's often value engineered out are elements which create flexibility, by the way. So things like putting office space around your diagnostic departments, which allows you to then expand into it, for example. So some real issues with that. But one of the other things that tends to get value engineered out has been art aesthetics and things which add to the patient experience. In the case of a hospital in Glasgow, the value engineering process has led to the introduction of an air conditioning system which has air changes which are massively below the industry standard and what constitutes safe practice. So it can really get you into very serious trouble. And in an attempt to save money, we also built these deep plan buildings, which is so large areas which have to be mechanically ventilated, don't have natural light, aren't great to work in, and actually it turns out may also be a problem in terms of infection control. And in primary care, we've not seen enough imagination to adapt to new models. There's an additional problem in primary care which might be worth mentioning here, which is the extent to which, while we've often got capital in primary care, often provided by quite a vibrant market of private developers, we don't have good mechanisms to fund the capital. How you pay for capital is a problem in the hospital sector. It's become even more of an issue in primary care, where the revenue consequences of building new buildings don't seem to be dealt with terribly well by the way that primary care general practice is reimbursed. So we've got a lot of money sloshing about waiting to be spent, but difficulties in actually spending it because servicing the additional costs of new facilities proves to be a difficulty. When we actually came to design and build them, we found out, partly because from the first graph I showed, we don't build that many hospitals, so expertise to do it is in relatively short supply. British construction is not great. We've had a history in the buildings of poorly supervised building with a whole series of problems. Those of you from Scotland will be familiar with the problem of walls actually falling down because they were not properly tied, including 8 tons of bricks falling into a playground just after playtime, due to the lack of oversight of contractors and big problems with, again, boring but really important issues like the proper installation of fire damping between areas of the building, massive problems with drains and water leaks all over the place, including again in Glasgow a water system which grows gram-negative bacteria at a rate that's really rather worrying. So these are little detail points, but we've lost a lot of the expertise and skills that we need to be able to do it, and more attention is required to them. The last program also really didn't take enough cognizance of the opportunities often offered by digital to reduce both the need for space for things for storage, office work, administrative staff, and others, but also to put digital tools at the fingertips of the staff, which got implications for what you build, but it actually means you need a different balance probably between building and digital in terms of the investment that you make. You will be aware from discussions today that the NHS's long-term record on workforce planning is as good as its record on capital investment. See my previous slide. And again, the workforce implications of new schemes and of the generally are not being sufficiently considered. We're now much more aware of the need for attention to carbon and sustainability aspects in design, but again, the last programme I think really neglected that. The physical environment, as Siva was saying in relation to, for example, the Alderhay Hospital, which is a really nice example, there is good evidence that daylight, pleasant environment has benefits for both patients and staff. We've cut it out because it costs money and because the papers, particularly some of the nationals, get in a twist because someone spent a bit of money on art, even though often it's given by charities. But these are civic buildings with an important purpose. They make statements about the town that they're in. People spend important parts of their life in them, and our staff, a large number of staff work in them. And there's no reason why they have to be sort of Stalinist and brutalist rather than pleasant. In primary care, I think, as I said earlier, we didn't really pay enough attention to what new design looks like. So some unfinished business that still needs addressing. The planning and approval process is massively cumbersome and slow, and although there have been attempts to speed it up, it's a real problem. There's also a real oddity at the moment, which is that the schemes that are in the pipeline at the moment effectively have to work to a budget, which is the number they first thought of, which is a bit odd because it means that an early estimate before they've managed to do the full planning and think through all of the strategic options that might be available to them becomes a hard budget constraint. And this is a particular issue. Siva was making a case for Whipps Cross. Let me bang the drum for Watford General, which I think has been in the pipeline for redevelopment at least as long as Whipps Cross, if not longer. But the answer that you might come up with Watford General will be different if you think about what does West Hertfordshire need, or Hertfordshire as a whole, than if you just think about what does the hospital need. So really, and the budget constraint that a number of hospitals have been given limit the opportunity for more imaginative solutions to cross-system solutions. Recently, the government made a very welcome announcement about increasing the amount of diagnostics, but there's more to do here. And the development of off-site diagnostics and indeed off-site surgical services is going to be an important part of, first of all, taking the pressure off some of our hospitals, but also, and I'll come on to this point in a minute, one of the lessons I think when we look internationally is that if you try and mix your planned work with your emergency work, the emergency work will swamp your planned work. And while we're trying to get hospitals to do both of these things at the moment, our chances of ever coming back to a reasonable waiting list look small. I've mentioned rehabilitation. I think really big opportunities here, both from private sector providers of rehabilitation, some good ones in the market, who can build hospitals much cheaper than the NHS can, but also can provide a way of improving some of our outcomes for stroke and trauma, which are not good even now, or for things like fracture neck femur. We're way behind what other countries are managing to do. We are length to stay at twice what theirs are, and we have, as a consequence, got a significant loss of productivity and quality of life. Just a few lessons from the pandemic that we ought to be building into our new into the new program. We've far too. So one positive thing about the pandemic is we made decisions much faster than we currently do when it comes to capital. We've also learned that we got far too few single rooms, and because of savings made to try and squeeze as much as we can out of the budget, that we got limited space in departments and corridors and very poor internal flows. And this is probably why we have had a nosocomial transmission rate in UK hospitals massively in excess of those we see in Germany and Austria, and where they have not suffered from some of these problems with design space and single rooms. We've also discovered that our engineering is underspecified, although just a slight caution here, we need to not try and prepare strategies for the next war using too many of the lessons from the next pandemic. May be a different one, but as it's likely to be respiratory, we should at least do something about the problems we've had with both oxygen and levels of ventilation and air changes that are available. One of the things that got value engineered out of many of our schemes was changing facilities and staff facilities. And I think given the fact that we got 90,000 vacancies and staff were catching COVID in their inadequate facilities, when we rebuild our hospitals, we should rethink what we do for staff. Interestingly, although Germany's got twice the number of hospital beds that we have, for COVID, they used hospital at home and virtual wards, which we did as well. But it certainly seems to have been, again, a crucial part of their early response. And again, one of the reasons why I think that some at least in phase 1 and phase 2 of the pandemic, they've done better. And then finally, I think a really important lesson is we need much more separation of planned and emergency work than we currently have. At the moment, the only way we could do that, if you say take Cheshire, just top of my head, the only way we could do that in Cheshire, apart from acquiring private hospitals, would be to close one of the hospitals in Cheshire's A&E department and turn it into a coal site. Good luck with that. So what other, I'm sorry if there's anyone from Cheshire, I just popped into my head, this will be true in any other parts of the country, don't take it personally, but what they've been doing in the Netherlands, who also have very small numbers of beds per thousand population like we do, is starting to build specialised elective surgery and diagnostic hubs. So there's a lot to learn from both what's just happened and what happened before, and as Siva said, flexibility, imagination and thinking beyond the walls of the hospital are part of the answer to that, which is where primary care comes in, because it's absolutely crucial, and where I think I hand over to Right Honourable Alan Johnson, who hopefully is there. Thank you.
Thank you, Nigel. And yeah, straight over to Alan Johnson.
Thank you, Chris. Congratulations to everyone involved in setting up this APPG. And to you, Chris, for being its first chair. The subheading of, I've been listening to Nigel for the last 20 years, by the way, and he's always good value for money. And I think his and Siva's presentations were well worth, were valued for money. I'm going to make mine shorter because to leave more time for questions, but the subheading for the meeting is the role of infrastructure in post-pandemic care. And of course, the first obvious point to make is infrastructure was crucial in pre-pandemic care, but it does need to be enhanced in a healthcare world that's going to be dominated by the NHS 10-year plan. And there seems to be a welcome return to integration. If I can quote from the government's command paper in February, it's an excellent quote: "Instead of working independently, every part of the NHS, public health and social care system should continue to seek out ways to connect, communicate and collaborate so that the health and care needs of people are met." And I think I haven't heard anyone in the NHS who doesn't agree with that. It's a very welcome message. We know that it won't be met if we don't improve health infrastructure. And we know that there's a backlog of 6.3 billion in maintenance. We know that a fifth of the acute sector infrastructure was built before the NHS was created, although that excludes primary care, which I'll come on to in a second. The capital spending review settlement, as Siva said, was good news, as is the commitment to build 40 hospitals. But the primary care estate still lacks the focus and funding that it needs to support community-based care, and some of the things that Nigel was talking about integrating the different services and providing the facilities for that. Primary care is the gateway to the NHS, but it's often provided through substandard, crumbling buildings that weren't fit for purpose decades ago when they were first constructed, let alone now. Local Improvement Finance Trusts, LIFT, were established by government 20 years ago specifically to address this problem, as well as the isolation and dangers, as we know post-shipment, of single-handed practices, and also that aspect of health inequalities that relates to under-doctored areas. It's probably, I would say, the most successful public infrastructure project that no one's ever heard of. There are 49 lift companies right across the country. They've now provided 350 health centres, 90% of them in areas of above average healthcare need. And I always like to refer back to that leaflet that went through everyone's door 2 months before the creation of the NHS in 1948, not because I received it, even I'm not old enough to have been there in 1948, but it set out 10 paragraphs of what you can expect from your NHS. And paragraph 10 said, health centres in every district. We've talked about lots of other services provided on the spot, direct lift, and of course, lift to use a term, and of course, it just didn't happen. But lift is more than just the delivery model. It contains a wealth of experience and expertise on strategic estates planning. We know how to build iconic healthcare facilities in lift and maintain them in day one condition. And that experience and expertise can be used in other areas of the NHS. There are no water handovers in lift buildings. There are none of these horrendous problems that were mentioned in some of the anecdotes that Nigel and Siva gave. I'm chair of City Care, the lift company in Hull. And last Friday, I was at the opening of the West Hull Health Hub. And the story of that, it was our 14th health centre built in the city, by the way. And the story of that is very much the story of primary care and the need for infrastructure investment in it. The GP practice moving into the West Hull Health Hub, it's called Spring Head. It was set up in a row of terraced housing in the 1930s, where it has remained ever since, except that its patient list grew, so it expanded into the flats above a row of shops nearby. Now you can imagine the problems here, and not just with the elderly, with young women coming with buggies. They just couldn't get into the building. If they could, they found it difficult to get up the stairs. It's a wonder that Spring Head worked at all, and it was classified by the Care and Quality Commission as one of the best health practices, GP practices in the city. Conditions were cramped, unsafe, unhygienic, and yet it was the gateway to the NHS. Great practitioners operating in awful conditions, too often the story of NHS primary care. Now they're in the West Hull Health Hub, an £8 million building with 32 practice rooms. There's plenty of space for integration. Philip Hammond's 2018 budget nearly destroyed this initiative, but thanks to the flexibility and patience of our NHS and private sector partners, we managed to adapt a third-party development model into something that looks very much like a traditional lift scheme, where the emphasis is on the whole life project, not in making a quick buck. So that's something that we need to address, because so far as I know, that 2018 budget still holds the line, i.e. there can be no structured public-private partnerships. And that doesn't, I mean, it probably was relating to PFIs, but we are not a PFI, we're a PPP, and there's public-private partnerships that are a world away from PFIs. Now, many of the health centres that Lift has built remain underutilised, as does much of the NHS estate. And we need data on underutilisation across the estate, so that as well as providing new buildings, we make proper use of those we've got. The NHS capital finance requirements can never be met by the public sector alone. We need a partnership that works, which just happens to have been around since the beginning of the century. Thanks, Chris.
Thank you, Alan. I think 3 excellent presentations there. Hopefully in the chat, there'll be some questions coming through, but do please raise your hand. I may not always be able to see it, but hopefully Mike will be able to identify people if you raise your hand, but do please put questions in the chat. If I can open up perhaps to Nigel first. I'm just wondering if there's, whether it's in the UK, whether it's more broadly in Europe, in terms of planning, are there any particular countries that get it right consistently, that there's role model, whether it's hospitals or primary care, whether they do it better in Europe that we could follow, or whether there's particular great examples? I know Oldley was mentioned, not Oldley, sorry, the Children's Hospital in Liverpool was mentioned earlier. But are there great examples in the UK that you think we should be following more closely?
Yes, thank you. Yeah, I think on the whole, it is done better in Europe. Unfortunately, I mean, partly as you saw, that there's just more money. There's been more infrastructure investment. There's less sort of, in general, across most European countries, there is less central government involvement in the details of how projects are set up and run. So it's much more local. I mean, so much more local initiative, a bit like the equivalent of Lift that we've just heard about there. In the Netherlands, of course, and Germany, a lot of those developments are done by independent providers, mostly not for profit, of course. But we've done better on standardisation, but not always standardising the right things. Alderhay is definitely a good example. There are a lot of you know, we have built some really good buildings, but the to some extent that's been in spite of rather than because of the guidance. I am hopeful that the new programme that's in place will help to spread good practice. That one of the problems with the last big programme was that a lot of the focus was on the procurement and financing model, and there was much less guidance given on how to produce really good buildings. But we're not massively over-endowed with very successful buildings from the last programme. Alderhay is a definite exception. North Bristol's pretty good. UCLH I think generally felt to work quite well as a building, but we haven't got the sort of standout buildings of the sort that, you know, for example, the Erasmus Medical Centre in the Netherlands, or some of the hospitals that we see in the States. Although they're often built to a different standard for different reasons, because they're in a much more commercial market, and there's perhaps more emphasis put on marble and atriums than is really absolutely necessary. but we have a lot to learn. And just a really important point about that, Alan just mentioned briefly, the concept of life cycle cost. Generally, when people in building and infrastructure think about that, they're often talking about the cost of the building and the engineering. But we need to think much more broadly when we come to life cycle about the impact on the entire service. So we build a smaller ward because it reduces the cost of the building and the construction, but actually it means you could staff that same ward with you could staff a ward with 4 more beds with the same number of nurses. So the life cycle cost of that that additional staffing cost dwarfs the savings that you made on reducing the number of square meters in your building. So I'm afraid we need a much broader, longer term approach to how we think about our financing, and that would be one of the lessons I would take from looking at our colleagues on the continent is thinking much more about the totality of the cost. And unfortunately, the Treasury and its rules and approach tend to push us in a different direction.
Thank you. Following what you mentioned, North Bristol, but if I can go to Bristol South, I'm sure following on from the words of Alan Johnson, Karen Smith may comment on that.
Thank you, Chair. Apologies for leaving late. Look, I'm really delighted we've got this group off the ground. It's felt like a bit of a lonely furrow sometimes talking about capital estates in the NHS in the last 6 years, and I'm such a big fan, particularly of Lift. Having been on the PCT board when we brought projects in Bristol and in my own constituency, the points made absolutely right about not using the space properly, not understanding it. I've had a difficult job re-explaining to new managers coming up through the system, very good, but that they've got these great assets and how to use them locally. I think the separation of estates under the Lansley reforms has left us with a real problem, and actually the current bill also doesn't really focus the system's attention on flexing its estate properly at a local level. So I think we have got a lot of work to do. One of my first jobs in the health service, I hear we talk about Watford and Whipps Cross, was the final snagging to Chase Farm A&E and the rebuilding of that back in 1989. And many people will know what happened to that particular project. And yes, North Bristol, I mean, again, it got a lot of criticism as a large PFI project. I mean, it's a superb building. In terms of sustainability, after some difficulties, it's a very efficient, sustainable building. And I just finally mentioned Philip. I see Philip Dunn, and I've just come from the new group of a timber supporting APPG, talking about how the timber industry as a sustainable way of building following COP is something also we don't do in this country, whereas on the continent they use timber and timber frame buildings more efficiently. I have a large timber business in my constituency, which is why I'm interested in that. Bringing all these things together to create a sustainable future, one that we all know, good healthcare in good buildings. I think on this group know we've got some levers here to use, and I'm very much looking forward to us being able to influence government policy back on that track again. And thank you to our brilliant speakers.
Thank you, Karen. I'll go to Baroness Hollins and then Baroness Finlay.
Thank you. Just, I mean, really interesting discussion. But what about mental health? You know, the infrastructure for inpatient mental health services and for rehabilitation is just really, really poor. And given our commitment to parity between mental health and physical health, and the fact that there really is no health without mental health, it just seems rather important to make that central to this work as well. I wonder what your thoughts are.
Thank you. So I'll go to the panel, see if anyone's got a comment on that. But Charles Walker actually made a pretty powerful point in the chamber yesterday, that where there's a general reference to health, it should be split to be physical and mental health to really focus people's minds. But who from the panel would like to pick up on whether it's anything from Karen Smith or Baroness Hollins?
Chris, just on that point about, it's a delight to see Karen as well, who's worked so hard to get these issues up the agenda in Parliament. But just on that point about mental health, the point I was making there and I am the chair of a lift company, but lift is a very important part of how you get buildings up, because all that knowledge and expertise, all that memory there over 20 years doesn't have to just be used on primary care. So in Hull, we're involved in the Mental Health Trust and the complete refurbishment and bringing all of their mental health facilities into one place and updating them. And God, does it need updating? Why would you have a separate initiative for mental health and a separate initiative for acute care when you've got a model there that can be used flexibly across the whole of the NHS? And we're actually doing that in Hull with the acute sector as well. And I'm sure others of the 49 lift companies in the country are doing the same thing.
Thank you. Anyone else from the panel, or I'll go to...
There are some schemes in the new in the hospital development programme that incorporate some elements of mental health, but many mental health trusts have got a complete sort of potpourri of accommodation, much of which is not very fit for purpose, is probably not very economic in how it's operated, and there's often losing the opportunity to be embedded with other services more effectively. And I think, again, one of the things that the NHS has not done well enough is how to use the wider public services, public sector estate to think about how to bring lots of different services together. So some of the best primary care centres we see, have got social care, got housing, social care. They may have criminal justice advice, systems advice, and everyone at the moment still got their own sort of pattern of unconnected services. My particular bête noire is on my way to work in Edgware. I drive past the Mental Health Resource Centre on a single-storey site, which is on the same footprint as a 15-storey residential block, just down the 400 metres down the road from a Zone 5 tube station. So think what you could do with the estate if you were more imaginative and you had more property development expertise, and you could create key worker housing, a mental health centre. You could bring in primary care. You could bring in other services. And I think that imagination and that expertise is really lacking from the NHS. We've not developed it, and the partnering and the partnering skills to exploit it are not very widespread. But where it happened, and that's probably one of the ways that we could do something with the mental health estate, because it's a bit of a mess. It doesn't lend itself to these sort of big schemes that the hospital sector does.
Thank you. Siva, do you have anything to say? Otherwise, we go to Baroness Finlay.
Thanks, Chair. Just two quick things to link two questions on mental health. I think too much of the focus, let me rephrase. The focus has been more on how do we eradicate things like dormitory style accommodation, and not enough focus given on what's the future clinical model of mental health support and how can that be supported by a different arrangement of the estate. And the second thing is linking to some of Nigel's points and a question in the chat about what my hopes and expectations are for the health infrastructure plan. That is a genuine health infrastructure plan that goes beyond the hospital building programme, important as it is. I think it is a different challenge if you look at how dispersed community assets are, how dispersed mental health facilities are. It is a different challenge. And I think that's one of the key things I'll be looking forward to from the next iteration of the infrastructure plan. Chair.
Thank you. Baroness Finlay.
Thank you, and thank you very much for setting up this group, which I think is as others have said, long overdue, actually. I've been really struck across Europe how in some places there's been extensive consultation with the population and with the staff in the design, and it's been an iterative process. It hasn't been consultation and then design, but they have been repeatedly involved all the way through. And there are some superb hospitals as a result. In the north of the Netherlands, in Groningen, where I was lucky enough to be for a couple of years, it's quite outstanding. And they're not encumbered by all the problems we've got of lots of bits of sticky tape and messages on the walls and painting coming off and corridors that are too narrow to get people down and so on. So I think there's a whole process about developing buildings. Maggie centres have done well, hospices have done well in terms of design, but it hasn't come across into our NHS estate. And part of that has been a complete failure, I think, to look after staff. I've been astonished to discover there's a new hospital just opened that doesn't have anywhere for the staff to go, even though they don't have a wobble room, basically. They can't go away from the ward for 5 minutes just to draw breath and come back out again into the clinical area, which is very high stress. And where nobody's realised that the windows from one part, the ITU, look into the maternity unit. So mothers in labour can see patients being intubated. It's just absolutely outrageous. And I can't help feeling that it was a complete failure of consultation with staff repeatedly to think about the flows through and to think about where things may be going in the future. And as Alan has said, we need to keep that memory of what's gone before, because again, we get projects, new people come in. It's as if this has never been done before, rather than providing a source of expertise. So I wonder whether you see this APPG as almost becoming a directory of a living memory of how to do things well and how to avoid things, so that there could be some kind of consultative ongoing role.
I think that could be a very important role for the APPG. We're coming down to the closing 3 minutes or so. So if I'd ask Siva, Alan, and Nigel each to perhaps take a minute as we draw to a conclusion, and I apologise to colleagues and the other questions that have been put on. We haven't had time, but I do think it expresses the need of this group, and I really appreciate the support that people have given and the questions asked. So if we can go Siva, Nigel, and then Alan for closing remarks, please.
Great, thank you, Chair, and really welcome this group. I think it's the most passionate group on healthcare infrastructure I've been a part of. I'd probably leave you with two thoughts. Again, at the risk of re-emphasising the obvious, we'll have a hospital building programme. I think unless groups like this keep a focus on the wider health infrastructure agenda, it will be all too easy for it to just drop off the map. And the second thing is, the introduction of integrated care systems could be an absolute game changer. You could have one place that sits across and has a strategic picture of all the healthcare resources, including broader one public estate resources, in a patch that's there to serve a community. And I think that's a really big strategic opportunity that shouldn't be missed. Thank you.
Thank you. Nigel?
Yes, thank you, Chair. I agree entirely with Siva. I think the one of the themes of a number of comments that people have been made is the shortage of expertise in this area, and a real need to rapidly accelerate both expertise in service planning, but also in estates and facilities and property development planning. As well. The other lesson, I think, which Alan has highlighted is, and indeed we've heard from the floor, is that hospitals are only one bit of the health system, and we need to also think about primary care, diagnostics, to community facilities and mental health facilities, and think about that in the context of the broader public estate is something that would also add significant value. Thank you.
Thank you, Alan.
Well, I do think this is, to echo my colleagues, this is a really important debate and discussion. Of course, to understand the problems with infrastructure in the NHS, you only have to look at what was there before 1948, because it brought together all those disparate parts. In Hull, when I became the MP in 1997, the maternity hospital was a 150-year-old former workhouse, 7 miles from the main hospital. It was a nightmare. So to tackle all of that, it has not been easy. Just one final point, just going back to what Baroness Finlay said. With clinicians, we want to get clinical expertise. We want to get the people who have done these intricate operations over and over again, and so have that knowledge and expertise. It's the same with the health infrastructure. You need to get the people who have expertise in this, on delivering these projects, looking at the estate, know how to consult as well as build on these things. So it's exactly the same principle, and it's one that we ignore at our peril.
Thank you, Alan. Thanks to all the speakers. Thanks to everyone for attending and supporting. I think it's been a very informative opening meeting. The next meeting is in the new year on the 18th of January, so do please come along. Do please interact with the APPG's website and Twitter account. If you are going to tweet, and I do recommend that you do, please remember using #HealthInfraAPPG. So thanks for that, and I'll see you next time.
Thanks, Chris.